I am Shinichi Hirose, President of AOCNA. I am honored to invite you to the 17th AOCCN in New Delhi, India from September 16th to 20th, 2025, where we will explore the latest advancements in our field. This Congress is a unique opportunity to network with child neurologists from across Asia and Oceania. It's a chance to build connections and share knowledge crucial for advancement of our field. India, with its rapid economic growth and rich cultural heritage, offers memorable experience both scientifically and personally. I firmly believe that face-to-face interaction are key to overcoming global challenges. I encourage you to join us in New Delhi to deepen your professional relations and foster collaborations. I look forward to seeing you there. Thank you.
Good evening. Welcome you all to the session for this month. And we have an amazing session this week. And the topic is very common migraines in children, clinical pearls from Dr. Alcy Torres from Boston Medical Center. Thank you, Dr. Alcy, for joining. Can I have the slides, introductory slides, please? Yeah. Dr. Alcy is Associate Professor of Pediatrics and Neurology, Boston University, and is Director of Pediatric Traumatic Brain Injury Program of the Boston Medical Center. And his area of interest is traumatic brain injury, pediatric neurologic disorders, and he focuses a lot on humanism, which is very clear to my heart as well. And has many publications and serves on editorial boards of many journals, well-renowned ones. And the experts today would be Dr. Biju Hamid, who was in Gosh and current in the UAE, and Dr. Hassan Tegul, another dear friend, pediatric neurologist from Turkey, and he's been very closely associated with these webinars, and a very well-renowned pediatric neurologist, and also the ICNA board. And we also have another dear friend, Dr. Vineet Gupta, who is a senior consultant, pediatric neurologist in Apollo Hospital. And he has many years of experience in pediatric neurology. Thank you so much, Tiwari. Dr. Richa Tiwari is our alumnus, and she's currently working in as associate consultant in pediatric neurology in Medanta, Lucknow. Over to you, Richa.
So very good evening to everyone. So happy to be a part of this forum today. So we'll be beginning with our first presentation by Professor Alcy, sir. Ma'am, shall we start the screen sharing?
Absolutely.
Right.
Any issue?
No. Sir, I kindly request you to please start your presentation. Is it visible? The screen is not visible.
Dr. Alcy, the screen is not visible. Asmita, any issue?
No, not for me. Do you want me to share mine?
Yes, sir, you can
Yeah,
share
yeah,
your
yeah.
screen.
Please share.
Here it is. Can you see it?
Yes.
Yes.
Okay.
It's visible. Yes.
Yeah.
So I request you to please, sir, enlighten us with this very relevant a very important topic which we'll be discussing today, which is migraine in children.
So thank you very much to Dr. Gulati and for your kind introduction and the moderator. I also want to thank you, the organizing committee, for always keeping me in mind to contribute to this meeting in the other side of the world and in the other schedule. For me, it is a pleasure to talk to you about a very common topic in pediatric neurology, for which, depending on what area you want to talk, this can take days and probably months, and still some areas that they still need to be uncovered. I don't have any academic or financial disclosure for this lecture. Perhaps mention that some of the treatments I'm going to talk about, like a lot of the things that we do in pediatric neurology, will be off-label, and that rather than a lecture that will focus on every detail of migraines, it will try to emphasize on the things that I consider that are important to know to be sometimes successful in terms of treatment. Little detail that might make a big difference. My learning objectives today are to properly identify and assess the children and adolescents with headache, to develop a management plan for acute headache and for the subset of patients who develop chronic headaches, to review unusual presentations and therapies, and to become familiar with available resources and evidence-based guidelines for headache care. If for some reason I don't mention anything specific, you should feel free to ask that question at the end. So let's start with something that I call case number 1, the angel. And here is the angel, just so you know. A young man presented with, I think it was a 16-year-old man presented with a new onset headache over the previous month that woke him up from his sleep. And so this question can come in clinic several times when you see lots of patients. And the first thing that the clinician should try to make sure it is whether this is something that will require workup or not, whether it might mean something dangerous or not. And the first thing when you hear that the headache is new and that is waking a patient from sleep is probably that you consider that there is increased pressure and you might want to do an imaging. However, and when you take the history, and this patient I have seen several years prior for concussion, the family knew me very well, and the patient that had the appointment was his sister, and his sister actually was feeling not too bad and give away her appointment to him just so he can go back to his boarding school on Monday. This is a Thursday. And in taking the history, he's a very reliable man who said that his headaches have completely resolved a week prior to his first neurological evaluation. So 7 days prior to seeing me, he just want to make sure before he goes away whether something needs to be done. And so this imposed the same question. Some clinicians might decide that symptoms have resolved, the examination looks completely normal, and in light of this, maybe do nothing, until the symptoms come back, if anything. But considering the situation in which he was not going to come back, I elected to do an imaging. And the imaging was done, so this is a Thursday, the imaging is done on a Saturday, and I received a phone call in the evening by the neuroradiologist saying that there's a large mass in the pineal gland that is almost about to occlude the aqueduct of Sylvius. So he was shipped immediately to Mass General in the emergency room. He was evaluated. He had imaging studies that showed this tumor. He was treated with chemotherapy for several months, and fortunately became tumor-free, and he's doing very well. And this is now 5 years after, and he has doing very well. So the family called this the labor of an angel and gave me this in memory of that. So headaches could be dangerous, fortunately not the majority, but it is very important to remember this. A second case, a 16-year-old male with a history of syncope, COVID-19 infection 4 months prior to the visit, who presented with intermittent episodes of dizziness several times a week. These events started abruptly and he appeared frozen, but otherwise he remained conscious and he's able to answer questions just slowly, but he can answer questions coherently. And subsequently, he resumed normal activity in less than a minute without any seizure, stigmata, or post-ictal period. So if you are able to see me in your screen, because I think the first appointment I had with him was telemedicine, he goes like this and freeze, doesn't really interact that much during that time, and the episode just goes away. So obviously there is a big differential, and some of you might think of neurology, some of you might think that maybe other organs need to be checked. So we thought that these episodes of dizziness, the sensation of I'm about to follow, might represent some cardiac disease. And so we obtained an EKG in the office. And the EKG, I'm not sure if it can be seen, but because we're neurologists, it's always good to point out exactly what the difference was. So this patient had a WPW syndrome, referred to cardiology, underwent an ablation of the network that was not working well, fixed the problem. And when we thought that the episodes of dizziness will go away, the episodes persist. And so this opens a big differential diagnosis. I'm sure you consider the possibility of seizures. So we captured the event several times. There was no associated seizure activity. We also imaged this kid in many ways in different times. And every time we did this was normal. When we did a full vestibular evaluation, everything to our surprise was also normal. And so with this, we consider a diagnosis that is a little bit uncommon in pediatrics, but because it has a very easy solution, I think it was vestibular neuralgia. But then there was no pain, right? So the vestibular nerve does not transmit as a main sensation pain. And so we came up with this. We thought that this patient had a vestibular paroxysmia that resolved with a very small dose of carbamazepine. And the response was abrupt, was really fast, really acute, demonstrating that sometimes a little intervention with the appropriate diagnosis can make a big difference. And so this patient has been on this medication for about a year, and I just tapered the carbamazepine. It's a very small dose, never therapeutic, for seizures. And the patient is still doing very well. The episodes didn't return. And because of his age, he couldn't drive. This was really affecting his quality of life. So it was really an opportunity to make a difference. And the last case, a 2-year-old boy with severe car sickness that started several months ago and progressively got worse. It was every time that the father put him on the car seat, on the car, they go around and immediately he will develop this nausea and vomiting that was persistent. He had a normal development. His immune system was unremarkable. And he did have family history of migraines, no car sickness, and his complete physical and neurological examinations were normal. So on this kid, because of the frequency and the severity despite his age, we decided to start him on cyproheptadine, and that make a magical response. And this, when we thought that we can share with the scientific community, we realized that our colleagues from Children's, so one of my fellows here, Lipson, had already published this paper a few years ago. So The prevalence in migraine, it is significant. It is, as you can see, it appears in very young children. I would say that even below 3 years of age, I have had patients that I have diagnosed with migraine equivalents. We can talk about that later. And as you can see, it doubles when you are in a school age. And this is the area in which boys have an equal frequency of headaches than girls. When they are too young, boys are more frequently affected than girls. And when they are teenagers, then girls are more frequently affected than boys. As you can see, the amount of people increases. Now, yes, this is a very common diagnosis. So children with recurring headache, 2/3 about might have one type of migraine, and an increasingly amount of headaches called the tension. Then I think depending on the series, the latest series will have a higher percentages, and in particular in headache clinics, this is the area that has been increasing the most. And this is consistent with the stressors of life, the stressors that adolescents have to face, different pressures, sometimes caused by limitations that have been underdiagnosed, like a learning disability, for example. And in the arrows, this is like just to remind you about the prognosis. So in boys, when families ask you about what are the chances that he will outgrow this doctor, in the case of boys, the prognosis is better, as you can see on the blue arrow. You go from 50 at 7 years of age, 50 to 36% on when you are on the 20s. And in the case of girls, unfortunately, it continues to increase, and almost 2/3 of them continue to have headaches throughout their lives. Of course, they do have periods that are post peaks and valleys, right? Patients that do well for some time. If we look at the whole spectrum of migraines and headaches in pediatrics, you can see that it is not it's hard to find the patient that presents exactly as the book or the international classification of headaches published by the society, the third edition, right? It is migraines without aura more frequent, migraine with aura less frequent, but an increasing amount of headaches on the right side, the tensional, psychogenic, or stress-related headaches on the right. But a group that it's hardly described, and probably a very common group, it is when you have different type of headaches on the same patient. And this is due to different factors. One is time, another one it is that our bias, that when we have a diagnosis, we think that in general it's hard to have 2 or 3 diagnoses, but that's possible. And so it is very important to keep this in mind if you really want to be successful and being able to educate your families. Patients presenting to the emergency room with headaches, the majority will have a viral illness. This is something that frustrates families around the world because before we couldn't do any testing, and doctors will say this must be a viral illness, and that's what's causing the problem. It has improved a little bit in our place because we're able to do respiratory panels that come back really fast, and we're able to diagnose many viruses, including flu. For instance, that, believe it or not, if you read about the symptoms of these different infectious illness, headache is usually a number 1 and very frequent symptom to present. And so a reminder of the importance of flu vaccine, for example. But then you have on the second, third line group, sinus, migraine. Of course, there is post-traumatic headaches after a concussion, or depending moderate or severe headache. You can severe trauma, you can have post-traumatic headaches, and this could be a topic for another time. And then other type of infections, and of course, tension type of headache. As you can see, that percentage, I think it varies. Tension headaches can be more frequent depending on the place, the hospital, and the social factors affecting social determinants of health affecting the population that the hospital sees. Now, it's important to understand, this is for my friend Hugo Arroyo from Argentina, says it's important to know, not only to make a diagnosis, because at the end you need to talk to the families. And so why is that they come to see you, right? Families come because they worry about brain tumors. These are sometimes the families that, unless you do imaging, they don't think that you have done anything. It's a very hard conversation to have. Headaches are bothering the child. Headaches prevent normal function, or they're just afraid to take too many painkillers as well. The doctors are giving him this much of pills to treat the abortive headaches and these ones to take every day. Doctor, I'm not sure that this is correct. I'm worried about the long-term side effects of this combination of drugs. So you need to identify why is that they're coming to see you, so you can address that and start helping the patient and put the parents on your team, on your treatment team if you want. So what should be the approach? Same as in medicine, you take a good history, you try to pick up on red flags, waking up in the middle of the night, in the morning, vomiting in the morning, double vision, worse with cough, worse with bending over or positional change, worse if you lay down, worse with Valsalva maneuvers. Those are important things to consider. New headache, lack of family history. So secondary causes, trauma, sinus, is important to us about snoring, if the patient is sleeping well, if the patient is on birth control, if there is a mood disorder, if there is an exacerbation of stressors or toxic exposures. Unfortunately, very common in industrialized countries, even starting at age 14. You want to ask for risk factors of idiopathic intracranial hypertension. So some of them might be obvious, like a young woman, overweight, taking minocycline or something for acne. That might be easy to suspect. But sometimes this could be in a person that, in a boy that is thin, and it could appear at any age, including pediatrics. And so it's always important to ask about eye problems and whether they have an eye exam. It helps you a lot on narrowing your differential as you're taking the history. It's important and something that we don't do it very well. We ask from 0 to 10, how much is your, in average, your headaches, but it doesn't really answer the question of disability. So there are some questionnaires that you can use to actually mark that, and that will help you to see if there is consistency between appointments, and that helps you to identify psychogenic headaches sometimes. And obviously you want to make sure that there is family history and ask about brain tumors and aneurysms, in particular aneurysms, not because of your patient, but because this might save several members of the family that they might have it and they were never given the advice that every first degree person in the family should undergo an evaluation for this. Okay. So it's important on your exam to document no meningeal findings, neck is supple, no kerning, no Brudzinski, normal iPhone, no focalities. In pediatrics and young kids, we really want to measure the head circumference. And one measurement doesn't answer the question. Sometimes the measurement could be normal, but if you see that has been crossing percentiles, then you understand why there is papilledema. But sometimes there is no papilledema, and only taking a look at the growth chart. So several times I might ask my pediatricians to send me copies of the growth chart if I cannot find them on the electronic chart. We pediatric neurologists will look for cafe au lait spots or white spots, because there are neurocutaneous disorders that patients might have associated with brain tumors or transformations of tumors or masses that might be the reason why the patient is experiencing these symptoms. And of course, a very thorough, complete neurological exam. So as you can see, we have 3 groups that clearly notice secondary headaches, and we're not going to talk about those today. Migraine is the topic of this, but because Dr. Gulati suggests that I should touch also on tension. We'll include that in our discussion. So here we go. Migraine in kids do not follow the criteria as you will see in the international classification. These headaches could be short, 30 minutes, a few hours if not treated. They could be bilateral, which is not the typical migraine in an adult patient, right? This might suggest actually tension headache. Might be less than 5 times. So you haven't counted, yes, he has not had 5 episodes yet. Not because of that is not a migraine. So how do you do that? You tell your patient, I'm gonna wait on the diagnosis of migraine until you have 2 more like this. I don't think we clinicians do that in the office. We might write it on our note, why it's the reason why we do it one way or the other, but if it is something that obvious, this is something important to take into account. And sometimes in pediatrics, you might have just abdominal pain, and that is a migraine equivalent, but there is no headache, right? There's no headache, and it's being treated just like that and answers like that. So there are differences. Now, do migraines cause sleep problems? Does sleep problems cause migraines? This was one of the lectures in our fantastic meeting in Turkey, and there was still no solution about which one came first, the chicken or the egg. I think we pediatric neurologists would try to treat both. Now, sometimes when we talk about aura, the symptoms that preceded the classic migraine, we tend to think about only the visual phenomenon, right? The visual scotomata or the fortification spectrum. I'll show you and why is that we use that term. But we forget that there are auras that are a little bit different, like a unilateral sensory loss or just a deficit, unilateral motor weakness, which is very confusing because it might be, this is with a vascular event like in a stroke, and with a speech disturbance, the same situation, or with dizziness, it might suggest another diagnosis. And so when these symptoms are preceding migraine and are not and resolved completely, and the workup is negative, it becomes clear, and they sometimes repeat it in a stereotype fashion. It helps you, but clinicians should be aware that weakness or paresthesias could be a visual aura, not only the spots that you see in here. You see in the Brandenburg Gate in Berlin on the left upper corner, you see this white spot that you cannot see anything on that park, or you can see that that fortification spectra in one of the squares in Morocco. On the right side, you see that they do not respect when this visual aura. This is important because sometimes visual loss can be just seen in a stroke. It doesn't respect really a visual field. And on the right upper corner, it is a medieval city from Europe that shows you exactly why is fortification spectra called, because the old cities needed to protect from enemies. They built these walls, and these walls have these shapes that, as you can see on the left lower part, it is fortification spectra. All right, so migraine with vascular migraine has changed the name, and now in the new classification is called migraine with brainstem aura. And this goes, it has to be 2 or more aura symptoms, and those could be double vision or visual disturbances. Is important, right? Double vision is not necessarily a bad thing, could be just migraine. But it's important to distinguish because sometimes a patient calls double what is just blur. And it's important to make that distinction on the description. Sometimes it could be just a slower speech or the patient cannot talk. It's difficult to diagnose this in young kids. And obviously, these kids end up being a workup because you worry about vascular events. So dizziness, vertigo, tinnitus, ataxia, bilateral paresthesias, pins and needles, bilateral paresis, on decreased level of consciousness. Those are the patients that are being admitted. Nobody knows really what they have, and then a day later, they go back to normal, and we suspect that maybe they took something, the workup was entirely negative, and they just recovered with no reason. It's important to remember this type of diagnosis. When the aura is prolonged, then you can have more than 60 minutes is considered prolonged, but less than a week, then you can, and this is associated with hemiplegia, you can make the diagnosis of hemiplegia migraine. And this has changed a lot, because about 20 years ago, we only suspect that, but we couldn't find any of the genes. And nowadays you have a variety of genes. You just mentioned a few groups down there, but there are plenty of others. And sometimes if you don't have the gene, that doesn't mean that you don't have the disease. This is an interesting syndrome. I have a young woman right now that I'm treating with acetazolamide. And you can use other medications. Flunarizine, for instance, that is not available in the United States. We sometimes ask from Canada. Sometimes it responds to the classic, but when it's not, then you need to go for these other treatments, and it's clearly familial. There is this very interesting pediatric presentation of a migraine, is a confusional migraine between 5-16 years, so school age adolescents. Episodes from 30 minutes to a day. These patients tend to have a head trauma on the history, and they present with imagine that I didn't talk about headache just for a second, and think about this sentence: sudden confusional state. So agitation, visual symptoms, dysarthria, memory disturbance. It's very hard to call that a migraine on the first event, right? But it is important to keep it on the differential, that once you have ruled out the other important diagnosis, that this might be it. Headaches usually precedes or follow the attack, not necessarily associated with that. And sometimes we miss this on the history because the episode is so dramatic that physicians tend to disregard the little headache before or the little headache after. Obviously, we need to consider different important things on the differential diagnosis. Infection, very important. We don't want to miss that one, right? Toxic exposures. These patients end up having sometimes extraordinary workup that shows normal, negative. If you do an EEG, maybe you get a delta range, but you don't see an epileptiform activity. And sometimes if you're lucky enough, and you do an MRA at the time of the peak of the acme of the event, you might see that there is some narrowing of some of the vasculature on the brain, some sort of like a constructive vascular syndrome that it is presenting rather in older people with a thunderclap headache, so something that goes really fast from 0 to 10, really fast. And then these patients return to normal, and because they have several of these episodes, then it becomes easier to make this diagnosis. When the headache has lasted for so many days, more than 3 at least, and they have been resistant to analgesics, or on the contrary, worse because of the frequent use of analgesics, and they are associated with severe symptoms of vomiting, prostration, dehydration that prevent the kid to go to school, to function in life. So these kids sometimes need a hospitalization for to treat, to maintain them hydrated, which is one of the important treatments, as we discussed, and pain relief. This is a minority of patients, but they really affect the quality of life. Some of them visit the emergency rooms a few times a year, and very rarely, when you don't treat a headache, in particular those that are associated with oligoemia, then you might develop an infarction, or sometimes even a seizure has been described. Tensional headaches are very common these days. At least 10 previous episodes fulfilling criteria B and D. So the headache can last again. It could be short, it can last for several days. And it has to have at least 2 of the following characteristics, as you can see: bilateral, pressure-like, mild to moderate intensity. And this is interesting, but not necessarily true in every occasion. They do not get worse with physical activity. And they do not have the classic signs, symptoms of migraine. So no photophobia, no phonophobia, and no nausea, no vomiting. And so if you have this type of headache, then you can make the diagnosis of tension, especially if you find on the history the stressors, which sometimes are not easy to pick up. Sometimes the patient doesn't want to share, doesn't want to tell you, and it requires several times to ask these questions to being able to make the diagnosis. Going from the bottom to the higher part, as you can see, number one, in the youngest population, we have two types of headaches. Motion sickness, you already heard me talk about in one of the cases. And another group of something that I call brief stabbing headaches. These are kids that are 8 months, 10 months, infants, 11 months, 14 months. And they complain with a very acute attack, stabbing, and it lasted for a few minutes, and then it just goes away. But obviously, this is very scary for patients and parents. These kids are worked up entirely. You do imaging, you do EEGs, you tap them, you measure the opening pressure, you do vascular studies, and everything comes absolutely normal. The family might have a history of migraine. This is a very important headache to recognize, because a small dose of prophylaxis with cyproheptadine might be able to help, or just any treatment for migraines that you use in older population. Then you have this group that we will, in the next slide, will go in detail, of benign paroxysmal torticollis. There is no headache, but this is syndromes that tend to follow by migraine. And so they are predictors that migraine will develop, and benign paroxysmal vertigo. And then periodic syndromes that you will see most commonly in adolescents, cyclic vomiting and abdominal migraine. So in the case of the benign paroxysmal torticollis or vertigo, these are usually infants or preschool children that are affected, and either episodes of tilt or episodes of unsteadiness. Ataxia, basically, they fall to the ground. Sometimes they appear frightened, sometimes they cry, but there is no loss of consciousness. And in the case of torticollis, if they are persistent, pervasive, you can use cyproheptadine. In the case of vertigo, it's a little bit more tricky, but you can use meclizine and therapies if the episode in older children than 2 years of age. On cyclic vomiting and abdominal migraine. So this is episodic abdominal pain or vomiting without necessarily prominent headache. In the case of cyclic vomiting, it usually appears at night, so very scary, several bouts of vomiting and non-stop, and they are very difficult to treat sometimes. It requires a combination of drugs to treat. I use sometimes for these patients, after giving the migraine medications and the usual medicines for nausea that we'll talk later, I use a little bit of lorazepam, and has been helpful for me. These patients tend to changes of color and family history. And like any patients of migraine, patients can have this history of car sickness, and it goes up to 50% of the children. So this is an important question to ask when you're taking the history. As you can see, there is detailed crisis. You see that. It's very important not to confuse, and being a neurologist is something that can happen. If you don't think in some other organs as the cause, if you feel that something is atypical, think about other possibilities. It's common to confuse cyclic vomiting with problems on the kidney, hydronephrosis that can produce in young kids with recurrent vomiting, episodes of vomiting, something that is called detailed crisis. Now, how do we treat those? So what are the goals when we treat all these problems, right? We would like a rapid and consistent freedom from pain and associated symptoms without recurrence. We would like to restore the ability to go back to school, to play in our kids. We would like to have a minimal need for repeat dosing or rescue medication. So try to be successful as fast as possible in a safe manner. And in older children and adolescents to be able to self-care and recognize when is that they need to treat ahead to avoid unnecessary visits to the emergency room, diagnostic testing, or other interventions. There should be, of course, minimal to no adverse events that will be probably not realistic. I always tell the patients that although not everybody develop every side effect, but there is a chance, and I go over the most significant side effects, and there's also considerations about cost. Treatment is individual, so you cannot have a recipe that you apply for everybody. If you do that, you will be probably not being successful in about 1/3 of the patients as being calculated. Treatment can be even tailored to the episode at the time of the day. So sometimes if the patient if you're treating this at night, you can use medications that produce sedation, but if the headache is in the morning, you want to prevent that to happen so the kid continue to function in a school or in a recreational activity. There must be a stepwise approach. Usually it's a little bit cumbersome because it requires several visits. You need to tune the treatment. We start low dose and we titrate slowly, depending on the presentation. Should be treated early. It's not a good practice to I have a headache and then wait an hour or two before you treat. The longer you delay treatment, just like in seizures, it will be more difficult to control. And then in pediatrics, we are using more and more combination of drugs and as well as combination of therapies to try to be successful or apply this in a more holistic way. As you can see on the left upper corner, the first line of treatment is fluids. I tell my patients you need to drink at least in a pediatric population, right, from 7 to 11 glasses of water, depending on the age. Actually, that has been calculated. I'll show you that in a minute. But something that I want to raise awareness of you is that you see that I put mindfulness, biofeedback, relaxation techniques, and biofeedback on the first approach. And it is because tensional is so common. And if you have a tensional headache, you might be able to break it if you apply those techniques successfully. So we don't leave that at the end. And perhaps it is something interesting that you might want to consider for your patients to be able to break the headache as soon as the headache is coming. We have several oral medications that I'm going to go over. The two new groups perhaps are GPANs and DTANs, as well as the combination of medicines that I talked to you. Intravenous medications, I think there has been not something extremely new. I think it's just what is available in our emergency rooms or that we are comfortable to use in pediatrics. Like I go over some of those. We have, fortunately, more and more medications that are available in nasal spray, including the triptans, the GPANs, and DHE that are very helpful in patients that have refractory headaches, and new techniques of treating headaches that I will touch briefly here. And as you can see, and it's okay to take a picture if you want, because otherwise it becomes like, okay, increase fluid intake. Then patients might ask you, okay, how much you want me to drink? And then you see it that according to age, there is a calculation that you can actually be used approximately, because no matter how many times you ask the patient to keep a headache calendar, and no matter how many times you have told them to drink plenty of fluids, this might be a little bit of a learning curve for everybody. And so anti-inflammatories, so first line of treatment, this is over the counter. It is since we learned that headaches or migraines are an inflammatory disorder, since Peter Goldsby from the UK that went to California has been also doing some research in pediatrics, but change a little bit our thinking, right? The old theory about vasoconstriction, vasodilatation, dilation of the cortical spreading of depression, spreading of Leao. That has changed dramatically, because that makes sense that ibuprofen will work better than acetaminophen. Now, if the patient tells me that acetaminophen is working, I'm not going to change it. Anything that is working, you just keep it like that. But scientifically, you can see that why ibuprofen might be more beneficial. And along the same lines, naproxen, we don't use that much diclofenac here in the States, but it's used outside in many countries in Latin America, as well as celecoxib that is more in adults or young adults. In the emergency room, we use ketorolac. I have used this by mouth in some patients that have very difficult headaches to treat as an outpatient, but I limit very much the doses because of the potential nephrorenal toxicity and gastric irritation. In patients that are already vomiting and giving, comes from my father, said, how do you gonna give ibuprofen, Elsie, if that irritates the stomach and somebody who is vomiting? And think about it, that makes a lot of sense. So we keep telling the patient takes ibuprofen because it's good for the headache, but if the patient has already some type of gastritis or GERD, this might not be the way to go. Now, triptans are selective agonists of these two receptors, 1B, 1D. You can remember the V as being on the blood vessel and D being on the nerve. And if you do that, these are serotonin receptors. And if you do that, you understand that why these medications might be very helpful in terms of suppressing the neurogenic inflammation and blocking the CGRP, the calcitonin GR peptide release. And the problem with these medications is that they produce significant vasoconstriction, and you want to avoid in syndromes that are associated with vasoconstriction. And side effects, flushing, dizziness, discomfort with the jaw and chest, particularly with the subcutaneous injection. It comes in nasal form and pills, and it's very effective. In children, rizatriptan has been approved to be used in patients as young as 6 years and older, and it comes in tablets and also oral disintegrating tablet, which makes it easier to use. There is a sumatriptan nasal spray that you can use in patients as younger as 6 years of age. This is off-label. And there are two other treatments that are used in pediatrics, almotriptan tablets and solmitriptan nasal spray, approved by FDA for treatment of migraines in adolescents 12 years old and older. Combination of drugs, sumatriptan and naproxen, has proved to be extremely effective in older children that 12 years of age. Now, the combination of the drug might be very expensive, but if you get sumatriptan and naproxen, individually, it might be more convenient for patients. These combination cocktails, as I said, are being in fashion. People want to be very effective. Look at this. The pain relief within 1 hour is pretty high for sumatriptan and naproxen. In the United States, we don't like to use aspirin. It is being connected to a Reye's syndrome, and being this a very bad disease, especially in patients that have flu, and being flu so common in the environment, we don't want to be in with the one case that will go alone and develop that. I use Fioricet sometimes out of I don't have any other resource. It's a good drug. However, there is not a good science behind it. And it is important to remember that because of the butalbital, it might be associated with addiction and withdrawal. And you want to advise your patients, because this might be helpful. The patient might like it and then disappear and continue to use. You need to really do counseling on that. If the patient is vomiting, you need to treat the vomiting. And for that, you need to use blocking the dopamine, which is a neurotransmitter widely distributed in the trigeminal vascular system. And this is important because it alleviates not only the nausea, but also helps you with the migraine. The most common, the one that we like, is metoclopramide, POIB. Make sure that you calculate the pediatric dose, max dose, 10 milligrams. Prochlorperazine, it is more effective, but it's more commonly associated with side effects. And so we tend to avoid that. And if you use promethazine, it comes also in different forms. This is pretty good for patients that cannot take anything PO. Then the problem with this is that it can cause QT prolongation and extrapyramidal manifestations. And in the emergency room, we try to diminish by using diphenhydramine Benadryl to help us with that. This is a new group, the DTENs, and this is a selective agonist of 1F serotonin receptors. The benefit of these drugs is that they do not cause vasoconstriction. Therefore, they do not have the contraindications of the other treatments. It is considered a controlled substance because it produces the high of the drugs, can produce drowsiness and dizziness, but is not yet approved in younger children than 18. There is the group of GPANs, the CGRP antagonists. I use rimegepant ODT with success, 75 milligrams every other day, and still you can use it if the patient has a migraine in between a dose as an abortive medicine. So it helps you being abortive and prophylactic medication at the same time. There are other presentations, very expensive, insurance rarely approved, but in adults, this has been proven very helpful for patients. You can just use an injection every month and you are free of headaches, or at least a significant decrease on headaches. So it is important to be aware what is this around. In the emergency room, when the patient has not taken by mouth, you need to take it by IV. I tell my patients that. And then you have to use a combination of drugs, anti-inflammatories, antiemetics, Benadryl, and sometimes the steroids we like dexamethasone rather than methylprednisolone because prevents you to have a recurrence of the headaches. You can use magnesium sulfate IV, but this is mostly in adults. I wouldn't feel that comfortable in younger children. There's not a lot of studies. We are very familiar with the use of valproic acid, and for the acute illness in a patient that does not have liver issues or metabolic problems might be a safe and effective way to treat, and you can treat that for a few days, right? You can follow up with that treatment, and if nothing else works, you need to admit and consider DHE that has a significant effective data. In terms of the steroids, obviously it's because of the anti-inflammatory mechanism that we use them. There is not a lot of clinical trials, but again, as I said, dexamethasone might help you to prevent the recurrence. And if you do that, you can follow up with a prednisone taper. In particular, we use prednisone taper when there is a significant or severe analgesic rebound headache, and the patient is not improving despite removing the agent. Magnesium, as I said, it's also increases the magnesium levels on the brain. This helps to modulate the hyperexcitability of the brain, but there is limited evidence on pediatrics. It works better when the magnesium levels are low. And in one adult study, there was significant improvement noted in patients with migraine with aura, and the max dose is 2 grams in adults. Valproic acid, it modulates GABA receptor, works on potassium sodium channels, has an inhibitory effect. There is not good data, there's only open label studies, but we use it anyway. And we all, I'm sure we have experience with this. There is not a lot of clinical trials on children and adolescents, but we use it because we use it comfortably with seizures. And because the numbers are good compared to DHE, look at this. Valproic acid response was 50% improvement in 1 hour, 60% in 4 hours, and 24 hours. So if it doesn't improve in the first few hours, it doesn't get better later. And if you compare with what happens with DHE, if you continue to treat for 24 hours, you reach out to the 90%. So you see, you have to, but if you use Depakote or valproic acid, you're not obligated to admit the patient. But if you use DHE, then yes. And if the patient has taken a treatment before, you need to separate DHE from the treatment for at least 2 days. This is a similar mechanism than the triptans. DHE is as you can see, it is an agonist for all these receptors. It has a pretty good successful rate. It's contraindicated in patients that have hypertension, stroke, vasoconstrictive syndromes. It starts, remember this, 2 days after the treatment, and then there is a protocol in which you continue to use this every 8 hours. And you should see an improvement in 1 day. Max dose is 20 doses. Produces severe nausea, so you have to pre-treat the nausea with an antiemetic, and there is this is available also in nasal infusion, in nasal preparations. Talking about infusions, lidocaine is pretty effective. There's one study with 26 patients in pediatrics, 90% relief with lidocaine infusion, and also propofol. This is for pretty refractory cases or when you cannot use other medications or the patient has significant side effects, then this has been proven successful. But this is in a small series, although I think we have considered that in 1 or 2 occasions. It's important to share the patient that medications alone or accommodations or lifestyle modifications are only one part of the treatment. There is also another group. There are patients that say, I don't like to take medicines. I have bad headaches. I have daily headaches, but I don't like to take medications. There are those patients like that. So it is important to be familiar that interventions like relaxation techniques, biofeedback, psychological treatments could be successful for the management of pediatric migraine. Also, the management of stress. So if the patient has really a psychiatric diagnosis, anxiety, depression, the patient needs to be treated for that. Even headaches could be the presentation of bipolar disease. So it is important to ask the questions, and depending on what you are getting, then you might use a different type of treatment. Sometimes a combination, sometimes you just predict, right, that the headache is going to be difficult to treat. You can, instead of delaying, you can sometimes try to do a more holistic approach to your headache. CBT is important in cases of psychogenic headache. And there are also a number of other techniques that have been used by our pain clinic centers when we refer our patients that have chronic problems in which they never appear to get completely better, but they get to a point in which they can function. And if there is this guy there that you can see in places that are difficult to get psychiatric or psychology help, you can refer the patients to this place, and patients that are enough motivated, they can learn several techniques. Although, as I said, some of the others like biofeedback requires professional training. This is very exciting because in pediatrics, they don't want to swallow pill. They don't like the flavor of the pill. The headaches are frequent. They don't want to take prophylaxis. They forget the dose. So patients have a number of reasons why they don't want to take traditional medications. Families might encounter expensive. Families might doubt in your advice. And so in these situations, having these neuromodulation devices have been really very helpful to me, because I feel like I have something else to offer to my patients that I didn't have that before. And so there are several systems. Cephally system use trigeminal nerve stimulation. Gamma core use glutamate suppression in the trigeminal nucleus. And TMS mini use threshold occipital cortex increase, and Neribio descending inhibitory pain pathway activation. These 2 systems are approved in pediatrics, Gamma Core and Neribio, and they are not very expensive. Cephally is about, well, I shouldn't say that, right? Because depending on where you live, it might be extremely expensive. It is about $200, and this allows you to get treatments, abortive and prophylaxis. So 15 minutes a day for prophylactic treatment. And if you have a migraine on top of that, you can get another 15 minutes and treat like that. So very convenient, almost like a G-Pan. And it is not to use alone, but if you use it in combination, I have a couple of patients in which this has made a significant difference. For patients in which they have tenderness when you press in the occipital region, I think a blockage with lidocaine or plus minus bupivacaine might be important to treat this type of headache. You can use also Botox injections, but they tend to be expensive. They lose the power over time. They develop these antibodies, and so people are a little bit reluctant to do that compared to I have seen that the occipital blocks are more preferred by the patients, and in some patients, you can do more invasive procedures like a sphenopalatine ganglion block. A very common diagnosis is analgesic rebound headache, because when the patient goes to the emergency room, the discharge was, okay, well, take ibuprofen, take every 8 hours, or Tylenol every 6 hours, but they never told the patient that this has limits. And so the patient comes a month after, 2 months after, 3 months after, has been taking this all alone. And what you have it is a migraine syndrome that transformed into chronic daily headache that has this component of elements of analgesic rebound. So it is not very well recognized in children. It is a paradoxical consequence. The patients ask you, well, but doctor, how do you say that? They gave me to treat the headache. And it's a little bit of a hard explanation. You need to educate the families on this. And sometimes just by removing the agent, you might be successful. If not, then we use several strategies, naproxen for a few days, just to break the cycle, or removing the agent, of course, but sometimes I do a steroid taper for 5 days, just to gain some time, because the family is right. What do okay, doctor, you want me to stop, and then what if I have a headache? So you need to offer that alternative and not ignore the call. And you will think that only ibuprofen or Tylenol can do this, but as you can see, any treatment that you use for abortive medicine, if you use it frequently, it will produce analgesic rebound. And to me, I'm not that comfortable in letting a person take ibuprofen 15 days. I usually limit this, and it also is a measure of my effectiveness as a clinician under treating headache. For me, 7, 8 headaches a month, that's my limit. And if a patient is having more, then I know that my prophylactic treatment is not working very well. So what is that we tell our patients, right? This is the moment in which this phrase applies pretty well. This is my motive most sublime. I shall achieve in time to make the punishment fit the crime. So headache calendar, drink plenty of fluids, but don't forget, need to be specific. Sleep hygiene, make sure that there is no snoring and that you rule out apnea. Regular meal times, analgesic overuse, you need to educate for that. Frequent follow-up until the family is empowered enough that they can manage the headaches and avoid emergencies. Set up clear expectations. This is not to treat completely. That will be a failure of explanation. Patients continue to have headaches. What is that? It will be less frequent, less intense, and you will learn how to manage that. And in terms of prophylaxis, those highlighted in colors are the ones that we use most commonly. So cyproheptadine in younger than 12 years of age, up to 12 milligrams in stages, 4 milligrams at night. There is liquid, there is tablet, sometimes twice a day, but you maximize the dose if there are no side effects and there is response. Amitriptyline or nortriptyline. Amitriptyline is a great medicine, I thought, until this article of the New England Journal of Medicine came a few years ago and say that amitriptyline or topiramate are not better than placebo. And so don't forget, it is the way that you say things in the office makes sometimes a big difference. And then again, once again, valproic acid. Gabapentin, sometimes when the pain is rather than migraine, is more neurogenic. And propranolol, an old medication for migraines, remember, cannot be used if the patient has asthma. But I mentioned this, I highlighted in color because these patients that have exercise-induced migraine might benefit from this medication tremendously. And then a variety of medications, including some of the herbals and neuropathic remedies. There are some that have data in pediatrics. And for those headaches that are not that significant, the patient is already taking a lot of psychiatric medications, I tend to go on a lower intensity, try to make things not worse. So I use vitamins or coenzyme or magnesium. And then the future. So there are some ongoing trials. We hope that the REMI-GPAN that finished their trial on December 31st, 2024 will become available for children. That will be a major change in the management of pediatric headache, migraine. There are some another study on safety and efficacy that will finish on 2027. Lasmiditan in patients, pediatric patients, and a study will finish in this year. Ubrogepant in patients that are children or teenagers, 2026, and the use of IV dexamethasone to avoid migraine relapse in the emergency room, and the nasal power for summer treatment. So, in conclusion, migraine is the commonest form of disabling headache and symptom in children. Migraine is a genetic inflammatory brain disorder affecting the brain, in particular the trigeminal nerve. Migraine can often be well managed by a combination of acute and preventive medications, and headache treatment could be challenging and requires multidisciplinary approach and likely a combination of interventions. Headache has inspired artists all around the world in many cultures. There is the Greek on the right upper corner, and Americans and modern art, as you can see on the left on the lower part. And with that, thank you very much.
So thank you so much for this very insightful, very lucid, and such a detailed presentation. I'm sure we have learned so much from it. So there are around 10 questions. We will have around 5 minutes to answer those because we'll have to move with the move
It's
ahead
okay.
with
You
the.
can continue. No, that's
We
okay.
can
It's okay. There are only 2 cases. Yeah, you can take time,
Okay,
yeah, please.
Take, ma'am. Right. So the first question, sir, is by Dr. Vivek. Sir is asking, what is your experience with Lisuride in children, especially in children who have a lot of nausea and vomiting? So kindly share that, sir. Your experience with Lisuride.
I'm sorry, glyceride or lithium?
Lisuride, Lisuride,
Oh
which
yeah,
is a
no,
dopamine.
we don't have experience for that, but we have read that there is people that have used and claim that that is very helpful. In the US, that's not approved to be used in pediatrics, and so I don't have that experience.
Okay. So the second question, sir. It is considered that is it considered that the acute stabbing kind of headache is caused by vascular reasons? So we had this vascular theory of migraine. So is it still valid that the acute stage, the stabbing or throbbing stage is because of that?
So not always, right? But it should be your first thinking. If somebody is presenting with a thunderclap headache and goes from 0 to 10 really fast, then you should consider vascular phenomenon clearly, even if the imaging is negative. So there are studies and case reports in which they do an MRI and MRA negative, MRA negative, few days later, and a few days later MRA, and small infarctions, and then in the MRA, finally vasoconstriction. And then, of course, those patients you need to treat with calcium channel blockers, and they will get better. And if you in repeated imaging, although patients don't like to repeat imaging when they feel that they are back to normal, but it is important, but not always. Because remember the cases that I mentioned on the preschool infant category? These patients had very sudden onset of headache, really intense. They scream, they grab the head, depending on the level of development and intelligence. And nonetheless, no matter how many times you do this workup, it remains negative. I think it is important to consider that vasculopathy is part of the differential diagnosis of a thunderclap headache, and that those are that's the category of syndromes that you want to rule it out before you put somebody in cyproheptadine that young. But I have done it, and it is work, and it has worked effectively.
Okay. Rita, before you go to the next question, we wanted to have the comments from our experts, Dr. Hassan and Dr. Vineet. And meanwhile, you can coordinate your questions so that, we have 2 cases also. So we can start. Dr. Hassan, your comments.
Thank you, Dr. Shefali. Thank you, Dr. Risha. And then thank you for excellent presentation, Dr. Asi Torres. In the first part of your talk, you clearly identified the red flags between the migraine and the migraine equivalent. I'm happy to see that. And then it is really important for the evidence-based management of pediatric migraine cases. And in the second part, in your talk, you provided the changing landscape of the treatment modalities in the pediatric migraine. migraine. We have different modalities, and also you provided some combination therapies for the migraine, pediatric migraine patients in the childhood period. I'm happy with that. We have options. We don't have a standard regimen, but we have some options depending on the case management based on the case-based analysis. I think in your talk, you maybe a little bit mention about that, what is the effect of the recent genetic testing for some kind of migraine types, especially for hemiplegic migraine types may have some mutation or maybe cogna mutation or SCNA1 mutation and an ATP1 mutation. What's your suggestion just on the restricted on the hemiplegic migraine subtypes, or you may be advised to genetic testing for any type of the migraine subtype? Thank you.
At this time, we only do it for hemiplegic migraine because it helps you to make the diagnosis to feel comfortable. There is a lot of anxiety at the beginning when you try to make the diagnosis, and also because these syndromes are associated with systemic symptoms too. Other organs could be affected, and it is important to understand. We're still not at the level that we send genetic panels for everyone. We know that it's familiar. We take the family history, right? And so we definitely know that. Sometimes we also, the family history is important for how the response to medications has been for other members. So the mother sometimes tells you, oh, topiramate has been my savior. Then it helps you, right, to make your decision.
Thank you.
Dr. Vineet?
Thank you, Dr. Elsie. Wonderful coverage of the right from the basics to the advancements, as usually do. As Dr. Tekul has asked about the gene test, a lot of when our parents ask us, what is the likely cause, and we say it is familial because either the mother, father, or they don't accept, but then they ask the history, they say, oh yeah, it is migraine. It is, but I never thought I take aspirin or whatever, 6 times a month or whatever. So we say it is genetic, and we know that as the subsequent generation, it is much more, a younger generation has the presentation at the younger age rather than the older generation, because as we know, if the mother is having started at 20, the younger child is likely to start at 10 or 8 or whatever age. So the question comes, as you have said, we are not doing any genetic testing except for hemiplegic migraine. They ask, the science has advanced so much, can't we do any genetic testing here? So how do you answer that question?
I missed the last part. Can you please repeat the last sentence?
When the mother asked that, are you sure the gene defect?
Oh, I see.
So what can we do about it?
So I explained that this is familial, that we still do not have the gene. We don't know exactly the region, but it's clearly that there are several members on the family affected. That the same happens with other disorders. If they're familiar with ADHD, for instance, I will use that as an example of people are tall or people are small. Yes, it runs in families, and yet we're not too worried to find exactly I want to talk a little bit more on only the hemiplegic migraine. I think this will apply for the migraine equivalent syndromes in a young age that we are uncertain, like a paroxysmal torticollis or paroxysmal dizziness or vertigo on the young age. We are uncertain. We might just do that. Or when we have a suspect for a syndrome that is associated with these mutations, that can also be associated with a headache.
Right. So it is most of the counseling rather than anything.
That is correct.
Right. So the other thing is the comment. Then when you said the first presentation in the ED room, the commonest cause is the viral illnesses, in about 39%. So a child, say 8-year or 6-year or 10-year-old, how long we can say it is the viral? I mean, the child is coming after 6 days, 5 days, it is persisting. How long do you think it can persist?
It's the symptoms, it's the clinical symptoms. Without symptoms, you cannot make that diagnosis.
Yeah. So
right?
headache at the presentation in ED, and you give him acute treatment and send him home, even after 5 days, 7 days, he's coming back with the headache, though it's dull, but it's persistent. How long you can say it is post-viral, nothing else?
So this is important. It depends on the virus. Look, if you look right now about flu, we have right now an epidemic of flu here in Boston, and it can last from days to weeks. Okay, but but we don't make a diagnosis if there is no the symptom, all right, or we tested positive the patient, right? If we don't have that, we just say, okay, this is a new onset headache. It looks that there is no focality in your exam is normal. I'm gonna wait a little bit, or you image, and then you just treat this as any symptomatically, this headache. So need to be careful in exaggerating also the use of the word virus, okay? It is common, but if you don't have a proof, I don't think we should use the term.
Child presented with the fever and then still having headache, and this is very common. We are seeing quite a
Oh,
lot of,
yeah.
and even after 5 days, 7 days, what is in your experience works best for them?
So there is a subgroup of patients that if the headache is intense or it keeps persisting, you still treat this as a migraine headache patient. Post-infectious viral syndrome exists, includes headache. And so sometimes I have given these patients prophylaxis just for a few weeks to come out of the cycle, because otherwise I will be acting against what I just tell you, not to use a lot of acetaminophen and ibuprofen altogether, because I'm afraid of rebound, very commonly after visits to the emergency room.
Okay, thank you.
Thank you. Thank you. I think Dr. Elsie, if you can see the questions in the Q&A and whatever can be answered, meanwhile you can answer them, and we can have the two cases, first from Turkey, then from India, and then we'll finish the concluding any questions left and the remarks, right? So Richa, please invite.
Yes, ma'am. So the first case will be presented by Dr. Cecil. He's from Ankara Bilkent City Hospital from Turkey. So I invite Dr. Cecil to please share his presentation. Meanwhile, ma'am, can we have one question until the time he's sharing?
No, please continue the case. It'll be a lot of hodgepodge, right?
Yes,
Please, let's
yes.
just have the cases. And Dr. Hamid is also there, the moderator. I think it'll be. Will you take time, Dr. Cecil?
Hello.
Yeah.
Yeah, please.
yes.
Please.
I
Share your
can't
screen.
open
Please, your
camera.
Oh, no problem. Asmita, can you help?
Yes.
Asmita, can you help?
Yes.
Even if the camera, Cecil, is not opening, no problem. Can you please share your screen, please? Just share your screen. It's okay.
I can share my.
Yeah, the share your screen at the bottom, the green
Yes.
one. And share your entire screen.
Yes.
If you have any issues, you can send to Asmita your presentation and she can do it. And meanwhile, we can go to the second case. If there is any issue. You can send me the presentation.
So then we'll ask Dr. Bijoy to
Yeah.
connect. Huh? Okay.
Yeah.
So until Dr.
Cecil, you send the presentation. Yeah, Dr. Cecil, send the presentation to Asmita. Meanwhile, we are having the second case first. Okay?
Okay.
Yeah,
Yes.
Dr.
So the second case will be presented by
try.
Dr. Bijoy. He's from RML Hospital, New Delhi. Can you please share your presentation?
I think Dr. Suchismita is presenting and Dr. Bijoy will be moderating, right, Dr. Bijoy? Fine. Okay. Yeah,
Good
Suchismita,
evening
share
to
your
all
screen.
of you. Am I audible to you?
Yeah,
You're audible.
everything fine, but share your screen fast.
Yes, ma'am.
Yeah, 5 minutes. You have 5 minutes, you know that, right, Peter?
Yes, ma'am. Is my screen visible?
It's visible.
Full screen kar dijiye.
Hello.
Is it full screen now on your screen?
Come on.
Ma'am, may I start?
Please, you have 5 minutes, right?
Very good evening to all of you. Myself, Dr. Suchismita Nanda, Senior Resident from the Department of Pediatrics, under the guidance of my Professor Dr. Bijoy Patra, we will be presenting an interesting case of recurrent headache, reversible hemiparesis, recurrent seizures, and status epilepticus. A 17-year-old male presented with chief complaints of headache, fever, and left-sided weakness of body for 2 days. History of present illness. The headache was acute in onset, severe in intensity, causing the child to wake up from sleep. It was located in the bilateral occipital region, lasting for the entire day with no aggravating or relieving factors, no triggers, no positional or diurnal variation, associated with projectile vomiting and transient loss of vision, lasting for 4 to 5 minutes with spontaneous resolution just preceding the headache. The fever was of high grade, undocumented, intermittent, associated with chills and rigors. The left-sided weakness of body was sudden in onset in the form of inability to walk without support, inability to lift arm to pick up an object, inability to comb hair or hold an object, associated with deviation of angle of mouth towards the right side, with slurring of speech and neck pain. There was no history of abnormal behavior or altered mental status, no history suggestive of a cranial nerve deficit, loss of sensation or abnormal sensations, involuntary movements or seizures, or any bladder bowel incontinence. In the history of past illness, this was the 4th admission of the child owing to these complaints. The first hospital admission was in the year 2012 when the child was 7 years of age. He presented with headache and episodic weakness of right side of the body for 2 months with no residual deficits in between. There was no neurological deficit, meningeal signs or features of raised intracranial tension at presentation. EEG and MR angio brain reported normal study during this admission. The second admission was in the year 2014 when the child was 9 years of age. He similarly again presented with headache and vomiting, followed by blurring of vision and left-sided hemiparesis. The third hospital admission was at the age of 10 years when the child presented with headache, altered mental status, right-sided hemiparesis, right-sided facial palsy, and absence of gag reflex. During this admission, the CSF study that was done, it was normal. The child also had an episode of seizure during this episode. Contrast enhanced MRI brain reported evidence of smooth meningeal enhancement in the parietal region. He was managed along the lines of pyogenic meningitis due to an inconclusive diagnosis. He was discharged on nasogastric feeds due to poor gag reflex, on oral valproate and propranolol. However, the boy improved gradually to regain full muscle power to present again with similar complaints at 17 years of age. As far as the birth history, the immunization history, developmental history, and personal history is concerned, it is insignificant. The child belonged to lower middle class according to modified Kuppuswamy classification. This diagram represents the 3-generation pedigree of this child. As we can see, this is our index patient. His maternal grandfather and the younger sibling have history of migraine with aura. The mother of this child has history of migraine with aura associated with intermittent weakness of one side of the body. She first noticed these symptoms in herself when she was 13 years of age, but the symptoms have never been so severe that needed any hospitalization. She had a last episode in November 2024. There is no history of headache in the paternal side of the family. There is no history of any sibling death. The father is a known case of pulmonary cox and has completed anti-tubercular therapy for 6 months. In general examination, the child was not oriented to time, place, and person. He was not oriented to time, place, but he was oriented to person. He was hemodynamically stable. In the CNS examination, there were no evidence of any cranial nerve deficit. In the motor system, there was hypotonia on the left side of the body with normal tone on the right side. The power was 0/5 on the left side of the body with intact power on the right side. DTRs was 1+ on bilateral limbs, and the plantars was bilateral upgoing. The rest of the examination was within normal limits. Course in the hospital. For the above complaints, the child was admitted with us initially in the ward. The fundus examination was normal. CSF study was completely normal. CSF CBNAT was also negative. He was managed along the lines of pyogenic meningitis with injection ceftriaxone and vancomycin, and anti-raced ICP measures were started. Injection valproate was added as a part of migraine prophylaxis. During this episode, he developed 2 episodes of seizure. Hence, loading dose of valproate and levetiracetam was given. However, his GCA started deteriorating in the ward. Hence, he was shifted to the pediatric ICU on the day of admission 6. In the ICU, he was continued on the anti-raced ICP measures. However, he went on to develop neurogenic shock, hence was started on vasopressor support. He was also put on mechanical ventilator due to deteriorating GCS. He went on to develop status epilepticus, needing escalation of the anti-epileptic drugs and the need to start on midazolam infusion. The shock gradually improved. No further episode of seizures were noted with minimal ventilator settings. Hence, he was extubated on day of PICU 3. The left-sided hemiparesis also resolved with no residual deficit, and he was transferred back to ward on day of PICU 6. A gastric aspirate for CBNAT was sent from the ward side due to a positive TB contact, and it came low detected with no rifampicin resistance, hence anti-tubercular therapy was started. The contrast MRI brain done during this episode reported sulcal effacement in the right temporoparietal region with very minimal meningeal enhancement. The MR spectroscopy also reported normal study. The EEG done during this episode was also reported normal. Now, summarizing, we had a 17-year-old boy who was admitted with us with recurrent headache preceded by aura, recurrent one-sided weakness, dysarthria, managed in the PICU for status epilepticus with complete recovery of weakness in between episodes, with a history of similar 3 admissions in the last 12 years. So the question that hovered over our mind was that, is it hemiplegic migraine? According to the ICSD-3 guidelines, there should be at least 2 attacks for a migrainous attack to be labeled as hemiplegic migraine. Our child had 4 attacks in a span of 12 years. There should be 1 or more of reversible aura symptoms. Our child had visual aura, motor aura, and speech aura. Our child satisfied all the 6 characteristics of aura as mentioned in the ICSD-3 guidelines. He also had positive aura symptom of visual flashes as has been described to us by him. The aura that the child experiences is fully reversible motor weakness, and it is also fully reversible visual, sensory, and or speech or language disorder. The next question came whether the hemiplegic migraine was familial in nature. For a hemiplegic migraine to be familial, at least 1 or more first or second degree family relatives should be suffering from hemiplegic migraine. As we have noted in the family history that the mother also suffers similar episodes to that of the child, migraines with aura, along with intermittent weakness of one side of the body. So with all this clinical background and a strong feeling that the child might be having hemiplegic migraine, familial hemiplegic migraine, we went on to do the whole exome sequencing for this child. A pathogenic variant of the ATP1A2 gene was detected in this child. The child was heterozygous for the above condition with an autosomal dominant type of inheritance. However, the diagnosis that was given by the geneticist was alternating hemiplegia of childhood. This diagnosis given by the geneticist really baffled us, because alternating hemiplegia of childhood is a disorder where the onset of the disease occurs before 18 months of age. And there are paroxysmal spells of hemiplegia, quadriplegia with chorioarthrotic movements, and dystonia. The onset of disease in our child was at 7 years of age, and he has never experienced episodes of chorioarthrotic movements or dystonias in these attacks. So alternating hemiplegia of childhood as a diagnosis was struck off from our list of differentials. The final diagnosis that we arrived was familial hemiplegic migraine. The next question was what type? So it was familial hemiplegic migraine type 2, where there is a mutation of the ATP1A2 gene, as Dr. Alci has already described it very vividly in his presentation. So familial hemiplegic migraine is a rare disorder.
I think Medasina, you had 5 minutes. Please go to the final take home, please. Yeah, case is very well presented. Just give the message. No need for nothing. What did you do? And no review of literature, please. Na? Yeah, just
Okay.
come to your take-home message. Thank
Ma'am, the take-home message is the diagnosis of hemiplegic migraine is a clinical diagnosis. The genetic testing is necessary to determine the genetic subtype. And neuroimaging with MRI and electrophysiological investigations like EEG have an important role in the differential diagnosis. That's all. Thank you so much.
Thank you. Dr. Bijoy, you were the moderator. Want to say something before I ask Professor Elsie to speak?
Thank you so much for the organic comment to give us the opportunity. And this case was really very interesting to us. In fact, this child was not followed for last 10 years, long 10 years. And because he came to ICU, we really struggled to make a diagnosis. And then finally we decided that in migraine, whether we should go for a genetic analysis or not, because that is not the usual practice. And we went for that. And to confound the matter, the child had also fever. And we have to rule out tuberculosis from the CSF or tubercular meningitis. But again, he had gastric aspirate, CB-NAT positive for gastric. We had put the child on ATT also. And the genetic diagnosis confirmed our diagnosis, and the child is on flunarizine and valproate, and the child is doing well. And because he has crossed 18 years, he is going to college also. That is so satisfying to know this. This child of children can be so successfully rehabilitated. Thank you.
So very interesting case, Dr. Nanda. Thank you for your presentation. Just
Thank you.
because of time,
Thank you
I'm going to
so
be
much.
very brief. So definitely the patient has the mutation. Definitely the patient has the susceptibility. But it is also true that the patient had high fever, and also that the patient had meningeal findings, and that the patient had a status epilepticus, correct?
Yes.
Right.
Yes.
So and those are not part of the syndrome. And so what I think is happening in here is that you can have a combination of things. You have the predisposition to develop the symptoms of alternating hemiplegia or childhood, which you had a history, but I think any other excuse, including a recurrent infection of the CNS of any kind, viral, autoimmune, of any kind, can give this mixed presentation. But you cannot make the diagnosis of pure hemiplegic migraine only on the basis of if you have a status epilepticus, right? That will be my comment in here.
Thank you. Thank you so much, sir.
Hassan?
But thank you for your presentation. It was great case.
Thank you.
You should present this
Hassan?
at the Kuna meeting in Boston in April. See what my colleagues
She should be
have to say.
present.
Thank you. Thank you.
Dr. Elsie, she should be submitting for the AOCC in September. And they know
That
it
is
is 5
true.
minutes. So the 24 slides were too many. So they don't know beforehand. I was not cutting them
Hassan
short. I have
Hassan
Turkey
has the
case.
hand raised. Hassan.
Yeah. Hassan has to speak. Dr. Hassan has to speak. Dr. Vineet, and then we have the case from Turkey. Yeah.
Yeah,
Yeah,
okay.
Dr. Hassan.
Thank you very much, Sushita. It's a great example for a precision therapy for migraine subclasses. I have a question about what kind of treatment do you selected? High dose flunarizine or any drugs for the cases, for the outcome?
Yeah, for the outcome, I think I should answer it.
Yeah.
For the outcome, actually, we try to prevent it through flunarizine. And valproate, we put the child on valproate. And with both flunarizine and valproate, the child is doing quite well.
It's great. Perfect. Thank you very much.
So, ma'am, shall we ask Dr. Cecil to please share?
Dr. Vineet, your comment, and then Cecil, you stop sharing the screen, Smita, and Asmita can start sharing. Meanwhile, Dr. Vineet, please, your comments.
Just one question, Bijoy. Excellent, very good follow-up. That's very less common in our society, in our culture, but nonetheless, the patient is stick to you. The question was how long did you choose to continue the flunarizine in this case? Lifelong or 5 years, 10 years? Any?
Sir, the flunarizine we have started only after the diagnosis of the familial hemiplegic migraine was confirmed, and currently it's been 10 months, sir, that he is on this drug. So we'll keep him in follow-up and we'll see how he comes out. Since starting flunarizine, he has had no flare-ups, and thankfully he has not visited the ED till now.
Thanks.
With
Yeah,
the similar
thanks.
complaints.
Thanks, Suchimita. I'm sorry I'm cutting you off because we are already 8 minutes
Yeah,
past
yeah.
the time and we have friends from Turkey. And yeah, thank you so much for a wonderful case. You'll get your certificate or presentation by email. Thank you. And thank you that Cecil, you could ultimately share your screen. Make it full screen, dear. Sorry, Dr. Alsi, I think we'll have another 10 minutes. It's okay with you?
Yes,
10
of
minutes
course.
more is okay
No,
with you? Okay,
I'm
thanks.
fine. I'm
Thanks.
fine.
Okay, thanks. And
Remember,
Dr.
this
Hassan, I hope you have
is morning in this side of the world.
Yeah, I understand, but you have patients waiting, and Dr. Hassan and
Yes.
Dr. Vineet, another 10
12.
minutes. Yeah,
Thank
please.
you.
Yeah. Cecil and then Dr. Hamid's comment. We are waiting there. Please. Cecil, it's not full screen,
Hello.
dear.
Sorry for the connection
Yeah.
error. Do you share? Sorry.
Yeah, we
Yeah.
can see it. We can see it. Asmita, can you guide?
Yes. I try again.
Only your slides can be seen, but it is not full screen.
Full
Dr. Hassan,
screen.
can you tell how to make it full screen? Because maybe
Yes.
my accent may be different.
Do you share?
Yeah.
Yes. Distinguished colleagues, first of all, hello to everyone. Sorry for the connection error. It's an honor to present our CACNA 1A case to such an estimate group. Now I am moving on to the presentation. Our case, 13 years old, male, in August 2024, first admission to another medical center with
The
complaints of
slide
headache.
is not moving. Cecil, slide is not moving.
Yes? Not
No.
moving?
No. Did you share your slides with Asmita? If you did, she
Yes.
can share it. You shared, Asmita? Asmita, please share the
Asmita?
slides,
Yes,
please.
I share with
Okay.
Asmita. Sorry.
Okay.
Again.
You can share your whole
I
screen. Just share your whole
Secure.
screen.
Oh, connect very bad. Tam ekran görünümünde olmuyor. Sorry.
Seçil, did you send it to the Asmita?
No,
Yes,
Asmita called me. Asmita
Yeah.
called me. They're saying that
Kindly.
she's unable to share. She's unable to share the slides as well. That there's some problem with the slide. She started sharing again. She's trying.
It's perfect.
Yeah. Okay. Now it's
it's
done.
okay.
yes,
Don't do.
yes.
Yeah. And don't do anything, Asmita. You just do the way you were doing. Just don't touch anything. Okay. Please, Cecil,
Yeah.
go on. Just go on.
Yes, thank you. Thank you. Yes, our cases, go, please.
Asmita, next slide, please.
Asmita, next slide.
Yes.
Yes, Seçil, you don't
Our,
move. Yeah.
yes. Our cases, 13 years old male, in August 2024, first admission to another medical center with complaints of headache, numbness, and weakness in the right arm. Weakness and numbness last for 24 hours. Bilateral thrombing headache resolved in 12 hours with ibuprofen. Next
Next
please. Initial diagnosis, transient ischemic event. 5 days hospitalization with non-specific suggestion. Laboratory hemogram was normal. Electroencephalography awake was no epileptiform activity. Cranial MRI was normal. Echocardiography was normal, and all tests were normal, and he was discharged. Next, please. Now, personal and family history, prenatal and natal unremarkable, hospitalization at age 7 years old, a preliminary diagnosis of meningitis presenting with intense headache and fever, and now he is going to seventh grade student. His good academic performance, family history, non-consanguinity, his brother 17 years old, and his father cerebral arteriovenous anomaly, his brother and uncle with migraine history, uncle migraine history with visual aura. Next, please. He applied to our center for feature examination 20 days later after the first attack. And approximately 20 days later, in differential diagnosis, examination were performed to exclude the pre-diagnosis that I will list, for example, migraine with aura, hemiplegic migraine, cerebrovascular events, attacks, epilepsy with hemiparesis, brain tumors, stroke-like migraine attacks after radiation therapy, central nervous system infections, alternating hemiplegia of childhood, hereditary and metabolic disorder, for example, Milas, CADASIL, hereditary hemorrhagic telangiectasis. Next, please. On admission, neurologic examination was entirely normal. Hematological evaluation and cardiological evaluation and metabolic evaluation was normal, no abnormalities. Cranial MR angiography was normal. Sleep electroencephalography was normal. Next, please. Next, please. All examinations were normal, and we excluded the diagnosis I mentioned. And there was no attack when he first applied to our center, and he applied for future examination. He has second attack in September 2024, admitted to another medical center with complaints of numbness and weakness in the right arm and leg again, accompanied by headache and speech difficulties. And motor and headache symptoms resolved with 12 hours. Speech problems with 6 or 8 hours was accompanied by articulation disorder and inability to find, for example, appropriate words for 6 hours. And then second admission to our center 1 week after, shortly after second attack, based on the anamnesis and findings and laboratory findings, we thought it should be hemiplegic migraine. Compatible international headache disorder, third edit hemiplegic migraine diagnostic criteria. Next, please. So we thought hemiplegic migraine etiology sporadic or familial. Hemiplegic migraine is divided into 3 subgroups according to genetic results. FHM1 is associated CACNA1A gene mutation. Another 2 is associated ATP1A2. And last 3 is associated SCN1A mutation. Next, please. Etiology is sporadic or familial. We didn't know. Genetic evaluation performed for 3 subtype GANs. Next, please. Our cases, genetic anomalous heterozygote mutation in exon 5 of CACNA1 gene, possible pathogenic variant according to ACMG 2015, anomalous of parents normal. We should be told it is a sporadic case because the absence of a history of hemiplegic migraine in first-degree relatives, and negative family genetic tests. So we thought sporadic case. Next, please. I can say something about treatment. We thought when hemiplegic migraine, with treatment use drug flunarizine 5 milligram per day and acetylsalicylic acid 100 milligram per day as prophylactic treatment. Many drugs can be used in treatment centers, may have different experience. For example, verapamil is used adults usually acetazolamide, flunarizine, lamotrigine, propranolol, memantine, for example, botulinum toxin A and topiramate. Next, please. Our case algorithm, January 2025, after treatment starting, after second control for attacks under flunarizine and ACA treatment, October 2024, similar to previous ones, but Miltrite Parazine, November 2024, only headache. January 2025, 2 headache attack. So that flunarizine reduced the attack severity and frequency benefit from the treatment. So I say something to studies. Our case is sporadic, we thought. Studies suggest that 20% of sporadic case maybe have a genetic mutation. I say that, and that's all. Thank you.
Okay.
Dr. Hamid?
Dr. Abid,
Dr. Hamid,
any
your-
comment?
Yes,
Hamid, your
yes.
comment?
Yeah, thank you so much. Good evening to everyone. As we decided to present the case, we tried to highlight 3 points in hemiplegic migraine. One is that genetic screening is especially in pediatric course and the course including patients with early and severe onset disease have a higher rate of the mutations. And additionally, in sporadic cases, mutation can be rarely detected, so that mutation analysis may be recommended in depending on patient age and the clinical severity. In sporadic cases, maybe ordered in genetic analysis. And the second one is the triptan use in hemiplegic migraine. In cohorts, the retrospective large cohorts show triptan is safe and effective in hemiplegic migraine attacks. However, is the use for hemiplegic migraine is controversial due to vasoconstrictive effect, and we have no experience with the triptans used in hemiplegic migraine. Another options maybe is hemiplegic migraine abortive treatment, as abortive treatment is dexamethasone or corticosteroid or hypertonic saline solutions, especially in cognitive mutations, mutated patients, as anti-inflammatory or as edema effect in, especially again in severe hemiplegic attack. So the third point is preventive treatment. In our clinics, we prefer as first choice in migraine, flunarizine or propranolol. We have experience with hemiplegic migraine is very limited. Approximately 4 or 5 patients with hemiplegic migraine diagnosed hemiplegic migraine, and we used flunarizine as first choice in the preventive treatment. Approximately 6 or 9 months approximately we use as prophylactic treatment in hemiplegic migraine. And the dosage is approximately 5 milligrams per day bedtime. And during the time, we didn't see any side effect, severe side effect. For example, extrapyramidal side effect, depressions, and then mental disorder. But especially especially is weight gain and feeling tired are generally reported. Thank you so much.
Thank you so much for wonderful case presentation. And I think I would request Dr. Elsie to give his comments on the case and also your take-home messages for then Dr. Hassan and Dr. Vineet for their comments and take-home messages. Yeah, Dr. Elsie.
No, about the case, Dr. Cecil, it was a great case, especially at the beginning of the training. I think it's fantastic to have those cases because it exposes you to something that is rare. But when it happens, it's good to be ready for the differential diagnosis. I would like to comment in the familial character because it is genetic, it is familial. It could be autosomal dominant, but it can appear de novo. So the lack of family history does not send you to a different path. The second thing that I would like to say about this is that this is a very interesting syndrome, in particular with the CAGNA mutation, in which there is a gain of function.
Function, yes, you're right.
Of the calcium
yes.
channels. And because of that, it appears that the hyperexcitability of the brain, it gets more severe, and even though it is on one side, it can produce a severe clinical presentation. So not only the acute neurological deficit, which is secondary to lack of blood, to decrease the amount of blood, but also a severe headache. And the last thing, I think this was mentioned before, it is that the treatment might be a little bit different here. You might want to choose the calcium channel blockers. Might be one of the ways to treat this type of headache. Just on the presentation, but excellent case. Now, the take-home messages. So frequent, we're all going to see this. Some of our colleagues don't feel that migraines exist in children. So we have a mission to educate the population and our colleagues that yes, migraines can occur in very young children. And that if the syndrome does not fit the classical presentations, we should keep always our brain open and alert because you might be able to find a little twist that helps you make a big difference. And I wish we can have one day the magic pill in which you just give that and fix it. But until then, we're happy to enjoy this journey of learning, of constant learning that we need to put in practice in every day and our daily lives in our practice. So thank you again, and leave to my colleagues on the panel.
Thank you.
Thanks.
So much.
There are three more questions which have come, which Richa can ask you in the end.
I'll take care of them as you continue.
Okay. Yeah.
So there are three more questions, sir. The first question is for ATP 182.
He's typing.
Oh, okay. Right.
He's typing. Sir said he's going to take care of while Dr. Hassan and Dr. Vineet give their comments because it's already very late. Yeah.
Thank you, Dr. Shefali.
Dr. Hassan.
Yeah, thank you, Dr. Shefali. Today we discussed the red flags for the pediatric migraine. Dr. Elsie Torres clearly mentioned that for the differential diagnosis of migraines and the migraine equivalents. And this is important for the evidence-based management of these pediatric migraine cases. And then my second message is that we have lots of options for the treatment but we have to follow some evidence-based guidelines. We don't use more medication to restrict it. Maybe sometimes we do combination therapy for the abortive treatments, and then also I advise single treatment or monotherapy for the preventive therapy. Choose the best manageable drug for the kids based on the comorbidities, something like that. Thank you very much. I really enjoyed this webinar, and also thank you for all the case presenters. This is my
Thank you.
take-home message, Dr.
Thank you so much. Thank you. And both the we'll be sending to both the case presenters the certificate by mail. And Dr. Vineet, your comments on the case as well as take-home messages.
Nice case, worked up as we wanted to. The only thing about the take-home, I would like to say that the diagnosis is really challenging in children. I mean, even as Dr. Alcia said, even in young children, the youngest I have seen is 3.5-year-old. It is very, very difficult to convince the parents that their child has a migraine. They won't believe you. They don't trust you. And so taking a good history, investing time in the good history in a busy OPD, it may be difficult at times, but that is the only way. And having said that, in spite of that, sometimes it may become really tough to differentiate whether it is a truly migraine or are we missing out on something which is going to be. So take your time before jumping the gun on any specific treatment. Of course, nowadays with so many medications, we have so many modalities available to us, non-medication, and Dr. Elsie has said nowadays a lot of parents ask about those non-medical devices. What is available?
Neuromodulation, yeah.
So that is it should be kept in mind, and that is the way in the future. Thank you. Thank you, Dr. Shefali.
Thank you very much. And I think on the other side, just wanted to flag one thing, that many times headaches in children can be psychogenic. And we have seen lots of them, which they may be having some other comorbidities. So just keep your eyes and ears open. And sometimes migraine and psychogenic may coexist. So so that is why just keep in mind, it's pretty complex situation in that situation. Richa, would you want to say something you learned, or you want to give some message before Asmita starts the video?
This was a very elaborate discussion, and I think this neuromodulation and neuromodulation techniques which are upcoming will be really helpful probably in the long run when we are exhausting all our treatment options. So I'm really hopeful that we'll see more of those in the future. Thank you, ma'am.
Thank you for a wonderful talk, Professor Elsie, as usual, and all the wonderful both the cases. And I welcome you all to the Asian Oceanian Child Neurology Congress in September. Please submit your abstracts. Asmita, can you show both these videos? Yeah, and thank you so much. Have a nice day and good night. We have 8 pre-conference workshops and 1 post-conference workshop. So you're all very welcome. Asmita, can you show this video? Asmita, any delay?
Thank you. Thank you, Shefali. Thank you, everyone.
Thank you. We're looking forward to meet you. One small message from Shinichi Hirose, which after this 1 minute, President AOCN. And he's sitting in his mountain house and he has clicked it in the snow very nicely and he wanted it informally done, very nicely done. Are you showing Professor Hirose's video, Asmita? It's a beautiful, I think. I haven't been to Japan and it's beautiful with snow outside and the fire inside the fireplace. Asmita?
I am Shinichi Hirose, President of AOCNA. I am honored to invite you to the 17th AOCCN in New Delhi, India, from September 16th to 20th, 2025, where we will explore the latest advancements in our field. This Congress is a unique opportunity to network with child neurologists from across Asia and Oceania. It's a chance to build connections and share knowledge crucial for advancement of our field. India, with its rapid economic growth and rich cultural heritage, offers memorable experience both scientifically and personally. I firmly believe that face-to-face interaction are key to overcoming global challenges. I encourage you to join us in New Delhi to deepen your professional relations and foster collaborations. I look forward to seeing you there. Thank you.
Thank you. Thank you so much. Thanks. Professor Elsie, you have neurotrauma there? You have seen neurotrauma is listed very nicely as the important special session. And obviously humanism will also have to come somewhere. So you can please think about it. I'll get back to you. Thank you so much. Thank you,
Yes.
everyone.